ಇದು increment that ಯಾರು ಬರ್ದಿಲ್ಲ.
So I request all of you to mute.
Pranash has not completed.
One second, I'll just mute everybody. Mute. Yeah, I think we are mute all. Yeah. All right. Good evening, everyone. I'm Dr. Prashant Gowda, Secretary NNF Karnataka Chapter. I would like to welcome all of you who have been consistently with us. Welcome back again. Today, we have got wonderful speaker, Dr. Rahul Anand Yadav sir, and he doesn't need any introduction. He's a great teacher, and I myself am a very big fan of him. The way he puts the things across out of the box, unconventional, but yet very interesting and very engaging. Thank you very much, sir, for accepting our offer to be in Karnataka chapter webinar series. Indeed, it's going to be a wonderful piece of information for all the youngsters and the practicing neonatologists. Thank you once again for accepting our request. So he'll be talking on newborn screening, followed by his talk by our own Dr. NILESH RAO. He's a consultant neonatologist at Cloud9 Hospital. Dr. NILESH, welcome for you as well. And today's session will be moderated by Dr. Kishore Kumar sir. Kishore sir, welcome. We welcome you as well. So let's begin the session. Over to you, Dr. Sir. Dr. Rahul sir.
Yeah, thank you. How to start now? Fine. Start us. How to make it full screen? Fine. It's okay.
Can you make full screen slideshow mode?
Yeah. Can you 1 second? We'll make a slideshow mode. Slideshow you can press. Just hold on.
Yes. You can just click on slideshow.
Sir, slideshow has been clicked, but it is not allowing to get into the full screen. I think some permission need to be given from their end.
Okay. Do you need any help, Rahul sir?
Sir, from here it is fine, but in
Just
the Zoom app they need to give some permission related thing.
To what?
To open a full screen.
No, nothing. It is easy. There's no need for permission.
I understand.
Open, yeah. Down, can you see here?
I think now it is fine.
Yeah. Okay. Thank you.
Can you see full screen, Prashant? Can you see full screen?
Yes, sir.
Yeah. Good. Let's start.
Please start, sir.
Yeah,
Please.
yeah, fine, fine. Good evening, friends. It's a great pleasure to be here. Actually, it's my great pleasure to be with all of you in these difficult times as well as challenging times. So, one more challenge we are going to discuss today is about screening in newborn challenges in specifically in rural area and
Can you
urban
keep the
area.
speaker little down, sir, because
Yeah,
it's
uh,
hitting the yeah, yeah,
like this,
yeah,
okay?
yeah.
Huh.
This is better, sir.
Huh. So we'll discuss about one more type of challenges. The challenge is about setup, like because all of we know that the screening is important, screening needs to be done, but when we actually start analyzing the practice differs a big way in rural area and urban areas. So what are the specific challenges we face in rural area as well as urban area? We'll try to find out, and we'll try to find out solutions also. In that, we'll discuss first of all growth, screening for growth failure, UGR. Extrauterine growth restriction is one of the commonest upcoming thing coming up when more and more small babies are being discharged. So what are the specific challenges in monitoring growth and screening for UGR? Next, we'll go for ROP. Retinopathy of prematurity is a very important disability these babies face. So what specific challenges they face in rural and urban areas, followed by hearing screening. As far as metabolic challenges are there, I would like to take my help of our colleague, Dr. Ganesh. At appropriate time, I'll call him this one. So let us first of all, we have to understand what is the meaning of screening. Now, when screening is there, usually many people still they consider it as something like a fashionable thing or a new thing, or it is optional thing. But screening is very important as far as picking up the cases before clinical features become advanced. Now, if you see this slide, there is a point of contact. Now, this point of contact is not necessarily birth. It is the point of contact means when the caregiver comes in contact with the baby. Now, this is a baby; it is not a patient. Now, after some time, clinical features start. Now, though clinical features start, they are not brought to your notice. Then clinical features advance, and disease is advanced. Then baby is brought to your notice, and then you start treating. Then usually outcomes are poor. The concept of screening is picking them at right time, means before clinical features start. So in that situation, you are bound to have large number of tests, and yield is bound to be less. So because of that, we end up feeling sometimes that am I doing it unnecessarily? Majority of people in district places they ask whether it's really essential, because this test we are doing in a baby, are we converting a normal baby into patient because of testing him again and again, calling him for follow up again and again? So it is not so. So here we are testing and we are finding the disease before it is manifest, and so that we can follow more frequently when treat appropriately with better outcome. Now these outcomes without screening and with screening they differ, but not necessarily screening will lead to always good outcome. Some cases are also I will look out to see whether even if screening is normal, still baby can have some amount of metabolic errors can actually manifest. So there is always limitation for this screening concept. So we'll go through one by one. First of all, what are the prerequisites for this identifying this disease before clinical features are manifest? There are certain characteristics of disease, characteristics of test, characteristics of management. Disease should be common. If the disease is rare, then there is no point of testing for large number of people. But this is a relative concept. Common and rare, uncommon, these are just words. For example, in case of inborn error of metabolism, consequence marriage is a risk factor, especially if a previous baby has expired because of some unknown cause. Then the chance that this next baby will have some similar disease is quite common. So common disease is a prerequisite, not necessarily in population, but in given scenario, whether this particular disease is common or not. Disease should be have poor outcome if untreated. So suppose a disease anyway is quite benign, self-limiting and all those things, we should not subject the whole population for this screening. Disease should be common, disease should have poor outcome if left untreated or treated late. Test. Searching for a test for this disease, not necessarily it should be specific, but it should be sensitive. Sensitive means we have to pick up the cases. So false positivity is tolerated, but false negativity is not tolerated here. So test should be sensitive, should be available. Now here is the key problem. Majority of rural areas or semi-urban areas in India, they claim that so and so test is not available in this. So usually all the investigations are available, then you start NISU, it will never happen. First NISU started and then investigations arrive. For example, when I started my practice in Satara, I have to ventilate the babies without X-ray for 6 months. And my NISU running well for 3 years, and after that blood gas machine came. So this lack of blood gas machine did not prevent me from actually ventilating the baby, because there was no other way. So we should not actually wait for investigation to available and then you start. Once you demand for the investigation facility will come, because there's a demand and supply relationship. If demand is there, then supply is there. Supply is not waiting for you. So availability is something we should insist on, and we should drive the availability. Don't wait for availability passively. It should be easy to perform. This test should be easy to perform, easy to interpret. Here is the catch. Many times we do screening for the screening sake, reports come, difficult to interpret. In that situation, we should have discussion with metabolic experts. One second. There is, I think, shall I continue? So this interpretation of test is quite important, because the test results should not lead to unnecessary anxiety in family. At the same time, suppose borderline test is there, we should have a protocol for repeating the test. Third category, management. Management should be available. The classical example here is cystic fibrosis. In cystic fibrosis, we know that there is no curative management. We can manage the baby, but we can't cure the baby. At the same time, if cystic fibrosis is found out early, then we can improve the quality of life of that particular baby, of the person or family we can help. So even if curative management is not available for cystic fibrosis, we can improve the quality of life. That doesn't apply. It is not like hypothyroidism. In hypothyroidism, curative management is available. So management is available, management should be effective. So I will repeat, when you're embarking on screening, the disease should be common. You should have poor outcome if treated late. Test should be sensitive. Test should be available. Test should be easy to perform, easy to interpret. And management should be available, and it should be effective. Next, we will go for challenges. Now, I'm quite happy that this topic includes challenges. We didn't start with problems or deficits and all. They are negative. Challenge is something which is positive. Whatever difficulties are there, we are going to improve. So we have to change our mindset. So in general, India is going through a transition where we are not calling problems as problems. We are calling them as challenges. Challenge is something to be accepted and defeated. So what are the challenges? First, main challenge I think is main thing is about these challenges are not mentioned in guidelines, but they are in mind. It's a mindset. As far as screening is concerned, mindset of doctor, mindset of family, mindset of caregivers, that is the main challenge. Majority of us used to think that this screening is unnecessary, because we are actually subjecting a normal neonate for these things. So this mindset needs to be changed. Now, how to change the mindset? Mindset doesn't change only by class or lecture or something. It is changed by a collective effort and trying to find out whether that particular screening is going to work or not. So that data collection is quite important. So main challenge we are facing in rural area as well as urban area is mindset. So we won't talk rural and urban nowadays, because this rural and urban boundary is becoming very thin. So many times in big cities like metro cities like Chennai or Mumbai, we find islands of rural mentality. And many times, even in rural area, we find excellence like a urban. So we will call this as a metropolitan and district and towns. So metropolitan means what? Metropolitan means huge cities, quite big cities. Bangalore, Hyderabad, Chennai, Mumbai, Calcutta, Delhi. In these cities, there is a problem of plenty. We've got a lot of options about labs, a lot of options about tests and all those things. And ultimately, we get confused about how to select among them. Rural area, main problem is availability. Availability is not there. Nobody is waiting with screening test and hearing test and laser and all those things. How to generate that particular, build up that system in rural areas. For example, when I started practice, there was no ROP concept at that time in Satara district place. So I have to catch hold of ophthalmologists. I have to convince the families. Plenty of mistakes we did, and we learned over a period of time. And at the end of the day, we are able to build a system by which babies are actually screened at right time. So rural or urban we want call metropolitan cities and districts and towns. So we'll divide each of this topic into two. For example, we'll have the brief example of growth screening. Now, uh, growth screening means we used to call this as a monitoring. But this monitoring concept assumes that the baby after discharge is going to be with you for a long time, which is not happening in India. What happens when the baby is discharged, about to be discharged, or comes for first follow-up itself, we know that this particular baby is going this way or that way. So this first or second follow-up in this space, nowadays we are not calling it as a monitoring, we are calling it as screening, because we never know that whether this baby will come back or not for follow-up. So this growth screening problems in urban and rural area, common problem is dropouts. If you discharge certain amount of babies from NICU or hospital, very few actually keep on coming to you continuously for monitoring sake or screening sake. They will come back for a problem sake, like cough, cold, fever, but they are unlikely to come back continuously, all of them. So dropout is a big problem. Second problem in urban area, what we are facing is different growth pattern. This particular thing I would like to touch upon slightly, because we have been told that all babies should gain 10 to 15 gram per kilogram per day. But what we observe practically is, suppose if you get a lot of babies from different IVF centers, we know that some IVF center babies, they grow slowly, and some IVF center babies, they grow rapidly. Some families, so they differ from other families. So how to interpret this particular differing growth pattern, and among these differing growth pattern, how to identify a baby who is at risk? In urban area, there is a lot of parental anxiety. If we find out some percentile plotting or some BERA report, ROP report, then the anxiety sometimes is disproportionate. The problem may be mild, but the parents are quite anxious about it, how to tackle with them. Errors are quite common because in urban area, metro cities, big hospitals, the workload is more. So there can be errors in measuring weight, head circumference, length. And last thing I would like to touch upon is endocrine referral, because so many babies less than 25 week babies are going home now. Now these babies quite likely to develop UGR. So these babies are at risk of stunting. So is there any role for growth hormone? Can you pick up these babies at right time for growth hormone administration in childhood? So these points we'll try to cover. Rural area problem is not anxiety but mindset. In a rural person, especially a person who is a farmer or somebody from village, they think once discharge and one follow-up, second follow-up is enough. They think that repeatedly going to the city for this sort of weight, height, and all those is not required. They think that baby is fine. Another problem in district places is metabolic bone disease is usually missed. Usually we go by anemia, growth, height, weight, head circumference, but metabolic bone disease is missed. So many of these babies are actually living with osteopenia of prematurity. Stunting is more common in rural areas, especially those babies who are discharged from SNCUs. We observed that a lot of babies they have got stunted. And another one problem is crossing the centiles. Sometimes the rural area babies, UGR babies, they are actually, when you come for follow-up, they are huge, a lot of adiposity. So how to tackle that? They are actually growing too fast. So these problems we'll try to find out. One about, first of all, we'll see dropouts. What are the need of dropouts? If some family is not coming to you for follow-up, so rather than blaming the family, first of all, we have to find out why they are not coming for follow-up, because screening is effective only if follow-up is good. There is no screening program successful if follow-up is poor. So dropout is your main problem for success of screening, whether rural area or urban area. There are in general 5 common causes of dropouts. When I talk with the family, they came across some answers. One is, many people feel that it is not required. My baby is good. My baby is discharged. I'm at home. I'm happy. So why to go unnecessary to hospital just to show that and just to confirm my baby is good? Because it costs money. Transport is a problem. So especially during lockdown and all those things, dropout rate was more. So crossing the boundaries, going to city, again coming back, it was an effort. And another third thing, they never tell you, but we have to find out from the body language. They are not happy with you. The baby has improved, baby is discharged, they have paid the bill. They actually quite shown they're quite okay, but they're not happy with the hospital. So these type of babies, they prefer to go to different hospital. So not happy with the hospital is the commonest reason. And last one is criticism. This particular things, many times we don't understand, but when these babies come for follow-up, and we first of all see the head circumference, weight and height and all those things, our body language tells that you are not happy with the growth. So usually common mistake by majority of especially doctors who are junior doctors, they show that they are blaming the mother for poor weight gain or poor head circumference of the baby. So being critical approach of the treating doctor in first or second follow-up, they make the family avoid the hospital. So critical approach, costly, not happy with the hospital, transport problem, and they think it is not essential. So how to go for it? How are solutions for it? Predominantly, main common solution is pre-discharge counseling. Before discharge, usually 1 day or 2 days, the doctor should talk with the family, not only for fitness of discharge, but about the importance of follow-up here. So this discharge counseling, one of the things we'll see afterwards. Transport wise, optimize the frequency of visit. Many hospitals are having a set protocol for, say, first of all, we have to see weekly, then fortnightly, then monthly. This is very difficult for people who are living in districts or living in villages. They have to stop working, they have to arrange for transport, they have to come here, wait for full day, and then go back. So we have to optimize the frequency of visits. Those babies who really require follow-up, close follow-up, we should ask for close follow-up. Those who don't require close follow-up, we should not ask for close follow-up. So optimizing frequency of visits should be left to the consultant in discussion with the social worker. The social worker who is sitting outside, they are actually in tune with the people. They know that some people are come here, but they are not happy with these repeated follow-ups. So not happy, we have to first of all find out pre-discharge counseling itself. We come to know that this family is not happy with the hospital, unlikely to come back. Package concept. If at the time of discharge, if you give them a package, that first 2 follow-ups are fine. If you go for discharge after 1 month, if you come in between, that particular visit won't be charged. Some sort of package, some attractive package we can give to ensure better follow-up. A non-critical approach should be there. When a baby is not feeding well, suppose weight gain is suboptimal. In that case, first question asked is, are you feeding all right? How is the baby? Who is feeding the baby? So that sort of blame game actually avoids this future follow-up. They will come for 1 or twice, but they won't come again. So non-critical approach, pre-discharge counseling, these will improve the follow-up rate. Now pre-discharge counseling, what I observed is why they should come back. Some people are inherently careful, some people are inherently careless. So majority of families don't understand why I should come back again and again to see. So what I observed is there are two points on which they usually actually quite agree to come repeatedly just to ensure good outcome: height and IQ. If we tell them that post-discharge nutrition, post-discharge growth is closely coupled with development. The baby grows well, he develops well, his height is good and IQ is good. Especially this height and IQ, if you stress at before discharge itself, then the follow-up rate is better. Otherwise, they come for cough, cold and fever, but they won't come for faltering of it. Appoint one point of contact which is acceptable to family. This is very important in urban areas, because in urban areas what happens is that there are multiple consultants and usually the patient is admitted under certain consultant. But what happens is that that patient is not happy with that consultant, he likes different consultant. So usually what happens is that these patients come, then the receptionist asks them to meet that consultant only, to which they are not happy. So the patient should be given freedom. Patient should be given freedom. Suppose they are not happy with consultant A, they should be free to show to consultant B. Consultant A should not feel bad about it. So same thing will happen with other babies. So A and B consultant actually will, there may be some cross referrals. So this sort of, don't hold on the baby. Suppose the family doesn't want to show you, she wants to show to different doctor or something, we should encourage that. If you do few things, then dropout rates come down. Now I'd like to come out of differing patterns of growth. Now we know normal baby weighs 2.5 to 4 kilo, head circumference 33 to 35, length is 46 to 50 centimeter. But it is not true in those babies who are preterm and growing. Those babies who come from actually low socioeconomic status, those IVF centers which are doing IVF at a cheaper cost, they usually grow differently than those IVF babies, those who are charging high, because that is a selection of socioeconomic status. What I observed is that their growth patterns, they differ. How they differ? Like this. Percentile of birth is depending on intrauterine growth. The intrauterine growth is depending on socioeconomic status and uteroplacental status. Socioeconomic status is not the only factor. It is closely coupled with uteroplacental status. Uteroplacental status and socioeconomic status determine intrauterine growth. Intrauterine growth will determine percentile at birth, and from percentile at birth, Postnatal nutrition will determine percentile on follow-up. Now, how the percentiles cross? So this we know. This is the usual chart we show. If you see, there are, first of all, we'll focus on weight. These are the weight charts, percentile charts are there. Now, if the baby is actually growing very slowly, then it leads to which is small for height will be less, weight will be less, stunting can happen. If the baby is crossing the percentage very rapidly, the baby is at risk of metabolic syndrome. So if the usual baby is crossing a percentage very rapidly, this baby is at risk of obesity and hypertension and diabetes in future. So this particular thing should be actually communicated with the family at the first few follow-ups. Now, what are the patterns we see? There are, after all of us, we know that after birth, all babies lose weight. All of us, we know that they regain birth weight and keep on growing. Now, based on what is the percentile at birth, this behavior differs. So first of all, we'll focus on middle one, that is AGA. In AGA babies, they lose weight and they gain weight steadily. That all of us we know. Now go to the first part, top one, LGA. They lose more weight. If a baby is LGA, is bound to lose more weight than usual. And once they lose weight, if the growth pattern, feeding is quite all right, they catch up very fast. SGA baby, that particular dip is shallow. They lose less and they gain less also. So this LGA, AGA, and SGA, depending on that particular behavior, baby's behavior during NISU or first few follow-ups, we can identify which baby is at risk. So this is also screening. So in the first one or two follow-ups, if you know that this AGA baby is crossing percentiles, SGA baby is crossing percentile, we should be worried. An LGA baby who is not crossing the percentile, also we should be worried. So this particular baby we have to divide into potential. Potential based growth charts are the need of the hour, but unfortunately they are not available. So we have to carry on with present charts. But in that, LGA, SGA, and AGA babies are going to behave differently. That everybody should understand, rather than blaming the family for both. Now, parental anxiety. Some parents are quite actually interested in knowing the weight. When they are waiting outside the OPD clinic, they compare your weight gain with my weight gain, others weight gain with my weight gain, and they get depressed. So some baby has gained one in 1 month itself 1 kilo. My baby has gained only half kilo and all those things. So these parents have to be told about per kg concept. The weight gain what we are counting is not in absolute terms. It is per kg concept. Weight gain 10 to 15 gram per kg per day is acceptable. So this per kg concept, once you tell the family, then they are realistic. They don't overfeed or overfeed the baby and causing aspiration, because some babies have actually gone for aspiration because of that. On one hand, there is aspiration. One hand, there is malnutrition. If you feed too much, babies are brought back again with aspiration. If you feed too less, then actually they are actually brought with EUGR. Well-being versus weight gain. A well baby is far better than a big baby. So well baby better than a big baby. That particular thing should be communicated with the family. Errors in judgment, measurement. So as we know that length measurement, weight measurement, hair circle measurement, all of them can have errors. So if it is falling out of way, then don't forget to repeat it. Don't make a judgment based on only one measurement, which doesn't happen to be fit into the whole picture. This one. Now I would like last touch on this one, endocrine referral, because this is going to come in future. Till this time, we blamed only the nutrition for height. We blamed only this SGA, LGA condition at birth for height. But now what is happening is in India also less than 28 weeker babies are actually surviving more and more. And these babies are not pre or preterms. They are preterm and IUGR. This IUGR component, which is present for months together before birth and exacerbated by postnatal malnutrition. Now this double whammy, IUGR and EUGR, very soon in India, we're going to have a lot of babies who are actually going to be stunted in spite of actually good follow-up and all. So last century, growth hormone is being rediscovered now. Now, according to this study, is in Korean Journal of Pediatrics, this one, role of growth hormone in stunting due to IUGR. Recombinant growth hormone is an effective treatment for short children who are born SGA who fail to demonstrate catch-up growth by 2 to 4 years. Growth hormone helps to achieve catch-up growth to a normal height in early childhood, maintain normal height gain throughout childhood, and achieve adult height with normal target range. Dose is 35 to 70 microgram per kilogram per day. It is costly. It will the whole course actually will require 1 or 2 lakhs, but this it is spread over a period of time. So those babies who are IUGR, extreme preterm, they are going to be candidate for growth hormone therapy in future. But is all those things are actually not yet happen routinely in India, but these are something which is more likely to happen in India in coming few years. So rural area, since I practice in rural area actually, so even if I'm practicing in metro, I do go for visit in districts. And there I find sometimes these babies are huge. They come on follow up and they are quite big. Then I was wondering what is the secret? Here we are feeding too much. They're not feeding. We are gaining weight, and here so big babies you are coming for follow up. Then they told me it is the secret is saccharin. In rural area of India, many places saccharin is very common and is popular. They add saccharin to the feeding. So this baby gets addicted to that particular taste and they keep on guzzling more and more milk and food. So this saccharin should be avoided because saccharin is actually increases the risk of obesity. What we want to achieve on one hand is malnutrition, one hand is metabolic syndrome. So we have to be we have to tell the family, especially in rural area, that don't use saccharin for these babies when they are growing. Now, metabolic bone disease. Everybody is aware about metabolic bone disease, but especially in district places, metabolic bone disease coverage is very poor. Metabolic bone disease, what is monitoring? Target population is less than 30 weeks. So those babies who are 30 to 34 weeks with one of the following risk factors, ladies, long-term TPN, cholestasis, steroids, loop diuretics. Now, we know that these babies are nothing but chronic lung disease babies. Chronic lung disease babies, this particular target population is changing. Previously, it was 30 to 34 weeks, but now it is going definitely less than 30 weeks. So in general, all these babies who are actually candidates for chronic lung disease should be screened for serum calcium, phosphorus, ALP, and if possible, vitamin D. Follow up monitoring serum calcium, phosphorus, ALP every 2 weeks until 40 weeks post-menstrual age. This metabolic bone disease awareness has to increase in district places, which is not right now. So all these parameters, calcium, phosphorus, are available even in district places. Don't hesitate to check the baby, investigate the baby on follow-up, especially hemoglobin, calcium, and phosphorus. Now we'll go to the most important part, that is retinopathy of prematurity. Retinopathy of prematurity, once we mention, actually, some people actually develop actually fear more than care. That is, suppose if I miss anything, and suppose after some time, the family sues me. So how to prevent that? So we should not go into that retinopathy of prematurity with fear. We should enter this field with a care that we have treated the baby successfully. We want the baby to see the world. So if you have the caring approach, then all the team members actually are on the same page and they go for it quite well. Now, what is screening criteria? NNF gives screening criteria less than 28 weeks and more than 28 weeks. Less than 1.2 kilos, more than 1.25. So this particular thing is quite good for the leader or senior consultant. But when it comes to sister or junior most person in your team, usually they get confused by this. Less than 28 weeks, more than 28 weeks, 14 to 21 days, 21 to 30 days. So what we have done here, this one, is that many times this weight and gestation don't match. The 14 to 21, 21 to 30 become more confusion. So what we have given is a standing order to all the caregivers, including sisters and all. Common factor here is 21 days. So in general rule is, there's no point of screening in first half of first month. And we should not delay after 1 month. So second half of first month, grossly good. Second half of first month is the ideal time for screening irrespective of gestation age and weight. Now this particular thing is why we are kept so vague, ill-defined. Because the ophthalmologist is not available daily, especially in district places. Ophthalmologist is not available daily. He's coming from metro city. He's coming from city, evaluating the baby and going back. So maybe he's coming once a week. Maybe he's coming once a fortnight. So we have to be practical. That particular exact 14 to 21 days may not match. Maybe actually screened at 25 days. Sometimes a baby which is bigger actually can be screened early here and there. So we have to be rationalize and optimize that particular screening criteria based on local condition. If that particular ophthalmologist is available, so better to screen earlier than later. If in doubt, screen the baby earlier. At the most, pathologists will see that the medium is opaque. I can't see anything. I know that only retinal is immature, that's all. But these so-called false negatives should not deter you from screening early. So, carry a message for everybody, irrespective of gestation and weight is, no point of screening in first half of first month, and don't delay after 1 month. So second half of first month is the time which is actually feasible based on ophthalmologist availability. Now mandatory screening for all babies less than 34 weeks. Now here is the catch. High risk babies less than 36 weeks. What happens is that these weeks are not written on case sheet of majority of these babies in district places. Weight is written. So in general, babies who are less than 1.75, those who require NICU stay, so those babies who are premature, we should give freedom to the caregivers, the nurses, junior most people, that to not to miss ROP. Not to miss ROP means don't be very strict into that particular, this baby should be screened, not screened. Preterm baby who requires NICU stay, suppose occasional baby undergoes screening, this one unnecessarily, that particular price we have to pay, because once it is missed, the retinopathic prematurity, it is devastating outcomes in future. So the test should be sensitive but not necessarily specific. This particular early screening, sometimes extra screening can happen, but that should not deter you from actually screening more and more babies. Next thing is metro. Metro cities, what happens is that the problem of plenty. When once you have got busy NSU in metro city, you are visited by so many people come to you, tell you that I'm good, I'm quite available. This one I got a lot of experience, and please this one let me participate in ROP program. Many hospitals approach you, many individual ophthalmologists approach you. So how to select the perfect ophthalmologist in that particular thing? So as we know that just like you are not perfect doctor, nobody is perfect also this one. So how to select, what are the factors we have to consider in selection of ophthalmologist? Second is, over period of we come to know that some ophthalmologists are very aggressive, some are very conservative. Some ophthalmologists, they go for laser early, they go for injections early. Some are conservative, they sit on the problem, sometimes they give for repeated follow-up and they use it at optimal time. One person's optimal time is one person's late, one person's timely is one person's unnecessary. So it's a relative concept. How to make a balance between this aggressive management and conservative management? This is the dilemma, a challenge faced by metro people. Another challenge here is whether to do the screening bedside, whether to send the baby to the ophthalmologist clinic, or whether to do the injections and laser in operation theater. ROP apnea. This is the main challenge, which is actually preventing ROP screening in large. Just like surfactant. What we know, that surfactant is very useful, but if you go to villages and all those things, people are afraid to use surfactant because of fear of pulmonary hemorrhage. Similarly, many people are actually afraid to do ROP screening program because of fear of apnea. ROP followed by apnea is very so common that nowadays because become like ROP apnea. So how to reduce the risk of ROP apnea, we'll see. And financial squeeze. Already this baby has actually, family has spent a lot of money. They are happy that baby is improving, and now they have to spend again for this ROP. So how to tackle this? These are the problems faced by metro people. Districts, there's a problem of scarcity. The qualified, experienced, dedicated ophthalmologist is not there in districts. Mindset of parents. The parents don't take it as very important seriously. They think baby is good, baby is discharged. Why you're again asking for this eye checkup and all those things. Negative counseling in metro. This is one of the very important problems for rural area, district places, because district places can screen, but for therapy they have to come to metro. Once they come to metro, the ophthalmologist in metro invariably says that you have brought the baby late. Then they go back to district place and their fighting starts, blame game starts, late referral. So these are the problems. So how to solve these problems, overcome these problems, we'll cover briefly. First of all, ROP apnea. Why babies stop breathing after ROP screening? When this baby is quite all right, improved from apnea, baby is quite good. So now we ophthalmologist walks in, then they put this one fix the eye, and they start screening. During or after this ROP screening, many babies go in apnea. Previously, at least, was going a lot of, the number was high. Nowadays, just number has come down. What are the common causes? When you analyze this ROP apneas, commonest cause was pain, agitation, disconnection of respiratory support. Suppose baby is on CPAP, HFNC, prongs or something. During this handling and all those things, disconnection happened. Aspiration. This baby is fed recently in last 3 hours. Because of crying, handling, increased intraabdominal pressure, aspiration happens. And most important part is side effect of the mydriatic drugs. The mydriatic drugs were actually quite common drugs, common cause of abnormal vital signs. And very important is neck flexion. Usually these babies have to go for neck extension, but many times during this, they go for pressure and handling and all those things. This particular neck support slips, baby goes for neck flexion. So we have to ensure, we have to tell the sister that this particular baby during ROP screening, there must be 1 finger distance between chin and sternum. Ensure that 1 finger distance is maintained. If it is not maintained, halt it, extend the neck and continue. See to it that whatever support is going on must continue. Baby should not be fed recently, and appropriate mydriatic drugs should be installed into eyes. Now, anticipation is the key. So when all these babies are undergoing ROP screening, it is impossible to go for this one. Not all babies go for these complications. Very few babies go for complications. So suppose when ophthalmologist walks in, there are 4 babies to be screened. You should know that in the list, there should be a star. Star in the sense, which baby is going to go for apnea, you should anticipate. How to anticipate this? Which baby is going to go for apnea? If those babies who are irritable already before putting eye drops, those babies who are already on respiratory support, those who are extreme premature, those who have history of apnea in past, those babies are actually have to be more careful. These babies are going to go for apnea more frequently. Now, how to prevent? Now, here is the one is caffeine, but caffeine is a double-edged weapon as far as irritability is concerned. So caffeine can lead to prevention of apnea, but caffeine can lead to irritability also. So if the baby is already irritable on caffeine, so we have to optimize the dose of caffeine. Selection of patient, selection of time, selection of drug, selection of nurse, and selection of doctor. These are important. Now we'll go for one. Selection of patient. When the ophthalmologist walks in, usually the ophthalmologist mentality is that ophthalmologist goes to the patient which he or she has seen last time. He is curious about last time patient he has seen. He wants to go to that patient again and want to see how is the condition of retina. And he finishes that patient, and the most high risk patient he sees at the end, and then the problem starts because drug effect is wearing off, the pupils are contracting, sisters are fatigued, doctor is fatigued, and apnea happens. Apnea usually happens out of 4 babies, last baby more commonly. So selection of patient. So request to ophthalmologist to see certain patient early and then see other patients. The high risk patient should be seen early, not high risk for ROP, but high risk for apnea. Selection of time. In general, this ROP screening should not be done in the evening time. Usually ophthalmologist finishes the OPD and then comes in the evening. At that time, no senior person is available. Or even if very shortage of manpower is there, there is nobody to intubate the baby. So try to do it in the time when there is lot of manpower availability. Selection of drug, that will come in next slide. Selection of nurse. A sister who is involved in the care of that baby should be present at the time of ROP screening. And she should be told that this particular baby should ensure the flexion of neck. 1 finger must go between chin and sternum. Selection of doctor. Usually every baby who is undergoing ROP screening and all those, there should be 1 doctor responsible for ROP program. In your team, we should earmark 1 doctor who is give appointment, selection of patient and all those things, so that he takes interest into that ROP screening and all. Management is intubation. If after ROP baby goes for life-threatening apnea, don't bag and leave it. You intubate first and then see afterwards. Selection of mydriatics. Now this is the thing I want to highlight, that concept of micro drops. Standard drop, it is actually delivers 26 microliters. A micro drop is 7 microliters. Now this older preparations were very strong. Phenylephrine was 2.5% or 1.25%. Cyclopentolate was 0.5%. Topicamide was 5% or 0.5%. Now currently what we did is we introduced the concept of micro drop technique. Micro drop technique is a small drop. Previously what was happening is drug overdose was happening. Though we take 1 or 2 drops or something, what happens invariably, baby is crying. Babies which quite difficult to give drops and all those things for sisters. And if the pupils are not dilated well, the ophthalmologist comes, shouts at the sister and goes off. So the sisters are scared about ophthalmologist more than you. So they invariably they put more drugs. Already drop is quite big. So drug overdose was quite common cause of this excess irritability and vital sign derangement, tachycardia, bradycardia, apnea. So once we went for this microdrop technique, the apnea and vital sign derangements came down. What is microdrop technique? 1 microdrop contains only 7 microliters. Phenylephrine we started use only 1%. Cyclopentolate 0.2%. So this phenylephrine cyclopentolate concentration came down, automatically ROP apnea went down. So complications of mydriatics. What are the complications? They can lead to systemic absorption. If you put lot of drug into eye, this eye is a very vascular organ, conjunctiva. So it absorbs in system, leads to hypertension, hypotension, tachycardia, bradycardia, apnea, arrest. Arrest means cardiac arrest, seizures, NEC, and sepsis. These are the complications of mydriatics. So, though on paper your drug may be going on well, actually in reality overdose can happen. So, better to treat less than more. Some baby whose pupils are not dilated, we can dilate again. Observers can come again tomorrow, but ask the sisters to don't over treat the eye. Selection of ophthalmologist. This is very important because out of all this availability, experience, skill, financial concession, previously we give a lot of importance to experience. These experienced people are not available. And available people are not having experience. So that is the problem. So in that situation, what we came to across is a team concept. A team has got a variety of people. Some are experienced, some are not, some are available, some are not available. So team concept is very important. If we come across some team of ophthalmologists, then even if one ophthalmologist is not there, second ophthalmologist can fall in. Second is, there can be second opinion. If the ophthalmologist is not available and whatever experience is there, the precious time is lost. Especially this is very important for district places. In district places, the ophthalmologist is available locally. He is not comfortable with handling the newborns. So we keep them away. A person comes from metro, then he comes and sees the babies and goes away. So there should be a good coordination between district ophthalmologist and metro ophthalmologist. If that coordination is not there, competitiveness is there, then many babies actually suffer. So availability is the first criteria, experience is the second criteria. So all of us were not experienced in the beginning. We gained experience after doing a lot of mistakes. Same thing with ophthalmologists. So whichever is available, dedicated, committed ophthalmologists who can come anytime, at least once or twice a week. Those ophthalmologists should be selected, and he will actually do the screening. If he required, he can refer the baby at right time to higher center, or he can take a scodobrain from different ophthalmologist. So he will develop skill over a period of time. Availability first criteria, experience second criteria. Team is better than individual person. Laser photocoagulation. Now, another second problem comes up in metro. The challenge is selection between these two, because some ophthalmologists they prefer laser, some ophthalmologists prefer injections, and both are having their own pros and cons. Laser advantage that disease regresses. Finite follow-up period, 50 weeks of post-conceptional age. 50 weeks. Lifelong protection from retinal tear. But it has got its own disadvantage. It is a destructive procedure. It requires anesthesia, close monitoring. Treatable areas of retina may be missed because it is peripheral, restrict peripheral vision, inflammation. It is a destructive procedure. So these are the drawbacks of laser. Injections, also there are advantages and disadvantages. It is very easy to use. You can give injection bedside. No anesthesia required, rapid response, better visual fields. Most important is myopia is less. If you see last century babies or beginning of this century, myopia was very, very common. Now also it's common. So those who improve from ROP, they suffered a lot of babies from myopia, high myopia, which interfered in the caregiving, they interfered in schooling. So that is less in VEGF. But it has got its own disadvantages. It will delay the vascularization. Recurrence is quite common. It's late recurrence. We think that baby is fine, but the ROP can recur later. We are just putting a pause button, like a lockdown for corona. We are just pausing it. Only after once you use, again it will grow. This one. Recurrence up to 60 to 70 weeks of post-menstrual age is quite long. When we are actually far sense of security, everything is gone. No, it will come back. Challenging follow-up schedule. Double-edged sword. It can actually flare up. Has neural vascular lung effect. Long-term effects are unknown. Dosage is uncertain. So good thing about these injections is myopia is less. Bad thing about VEGF is uncertainty in future. This one. Now these are the various drugs which came. We won't go into picture of this one, not too much onto that. Directly we'll go to this comparison. Injections versus laser. These injections may require multiple injections or add-on laser therapy. Just because injection doesn't mean laser will prevent it. Sometimes we have to prime the baby with injection, then give laser. Uncertain doses, require strict follow-up, better visual acuity. Laser, more efficacious, more complications, high myopia, easy to follow. So when one ophthalmologist is fond of injections, one ophthalmologist is fond of laser, we have to understand why. many times this particular laser is something which is actually one time. Injection has to be given multiple times. So why one ophthalmologist is actually favoring this or that? Is there a scientific reason or financial reason or convenience reason or time management and all this we have to find out. If it is scientific reason, then we must encourage whatever is there this one. So better is team concept. In team concept, where there's some people are favoring lasers, some people are favoring injections, so they discuss among themselves and they come to the better plan of action for individualized babies. Cost. So this cost is quite important to inform to the family when you're going for this screening purpose. Many times when they ask you about cost, if you say, I don't know the cost, your ophthalmologist, they feel helpless. And sometimes ophthalmologists actually, depending on demand and supply, sometimes cost can be varied. So laser costs between 10,000 to 60,000 per eye, depending on situation and all those things, but it is quite wide. So more and more you use, less and less cost comes up. Injection also. These injections range from 10,000 to 17,000. Screening 6,000 to 1,000. Now this is the basic cost. This one, this cost can increase and decrease depending on hospital and all those things. So cost can be managed. Now this we are putting, definitely these costs are not realistic, I know, but these are the just idea of a baseline. From that, we can optimize the cost based on that particular turnover. More turnover, cost goes down. Now, whenever you are seeing extreme preterm babies, and when you are thinking about ROP and all those things, we have to have the holistic view of that. Suppose a baby which is 23-weeker baby is there for a long time, is improved from all those things, and now he's having ROP or something. At that particular time, you should have sufficient turnover to request the ophthalmologist to help the baby financially. So don't keep on changing the ophthalmologist. If you keep on changing the ophthalmologist, no ophthalmologist will help you. But if you hold on to a group of ophthalmologists or one or two ophthalmologists consistently for a long time, then we can optimize the cost in future. This one. So this optimization cost, if you give reassurance to the family, the compliance improves. If this reassurance is not coming, then a lot of mishaps can happen. So there are again two types of ophthalmologists we come across: aggressive and conservative. Aggressive, they go for early anti-VEGF, early laser therapy. Conservative, they regular follow-up and critical decision making. So here, who is right and who is wrong will be very difficult to understand. The main way we can actually go for this one is request the ophthalmologist to take a photograph. Once you request the ophthalmologist to take a photograph, too aggressiveness or too conservativeness will go down. This observed. We across both instances. So if you request the ophthalmologist to take a photograph, it becomes an objective way. So a photograph can be compared. Your own personal impression can't be compared. So the easy way to go for middle way is to photographic comparison. Once you go for photographic comparison, sometimes we know that conservative approach works. Sometimes we know that some maybe aggressive approach works. So photograph and objective comparison in photograph will guide you whether aggressive or conservative should be done in this particular baby. Now districts, in districts as far as now infant visit of an experienced person versus availability of inexperienced person. I would like to go for availability of inexperienced person in beginning. Slowly that person will become experienced, and that should be actually supported by somebody who is coming from bigger center and who is having more experience but frequency is less. Here consistency is important. So one person seeing the baby over a period of time is very important rather than multiple people seeing the baby's eye number of times. Now mindset. Because when I started to practice in different areas, including tribal area and all those things, we observed that there was resistance for actually timely referral. Late referral is quite common from districts to metro cities for this therapy for ROP. This reluctance to give importance to it comes from prognosis, because we tell the family that better to go. Better to go, they don't understand must go, better to go, or may go or may not go or something. So they afterwards when they come and shout at you, they make the change in words. You didn't say like this. When they went to the metro city, they said that already you are late. So here we should have a very clear idea how to talk with the family. When you're talking with the family, giving a vague idea that if you go early, prognosis is good. If you go late, prognosis is not good. That is not sufficient. Usually family understands the concept of 50-50%. And family also understands the concept of 80%, 90%. So let us come to the type 2 part. Type 2 part is where risks is less than 50% of unfavorable outcomes. Mean almost 80 to 90% babies they do extremely well. What are they? Zone 1, stage 1 or 2 without plus, zone 2, stage 3 without plus. We should not go in detail of the staging and zones and all those things. In general, we have to tell them that if you go early, if you treat early, 80 to 90% success rate. If you treat late, it is only 50% of success rate. Choice is yours. Once you see these 2, 3 sentences quite well and with a scientific background, then they're convinced and they actually understand the importance of going to metro city or whatever ophthalmologist timely. Next thing is this confusion. Many cases also happened. Court cases happened. Many times, a lot of uh, uh, so many times we come across something which is actually what happens is that there is no any coordination between ophthalmologist in metro city. There is no coordination between ophthalmologist in district, and there is no coordination between district pediatrician. So these negative counseling happens. So that neonatologist had treated the baby successfully quite well. He has spent a lot of time, energy, and all those things. Baby is improved. They screened, found ROP. This baby went to higher center like Bangalore, Hyderabad, Chennai, Mumbai, and the ophthalmologist there tells that this is quite late. So this particular thing happens because of lack of coordination. What I observed is this one: ophthalmologists who are trained in one institute, they are loyal to that institute, and unfortunately, they don't practice in that periphery. They practice in different setup. So your job is to ensure coordination between these two ophthalmologists. A person who is locally available and person who is sitting in the metro city. They should talk with each other, and we should encourage that they should talk with each other about some cases. If they are already talking with each other, late referral does not happen and negative counseling does not happen. This negative counseling is the foundation for all the medical legal problems. If you avoid negative counseling, legal problem don't come up this one. Now, another problem in districts is that majority of doctors complain that I screen, I diagnose, I refer, I treat, but I don't know the complete loop, because after treatment there is follow-up. After follow-up again there is treatment. These multiple settings are there. So you should have a register of ROP cases. All the ROP cases, this one, who have been referred for treatment, there should be a flowing register where we come to know over a period of 1 year or 2 years, because these are the babies, they give us a feedback whether myopia was there or not, whether the associated problem was there or not, any associated schooling difficulty was there or not. So maintain a register of ROP. Those who are discharged, we should keep on following them. Even if they don't come to your OPD, still your caregiver can call them and ask about the condition of the baby. So these are the challenges in district. This one. Now we'll come briefly about newborn hearing screening. The newborn hearing screening, this one, first of all, as previously, we'll think about metro cities and districts. Metro cities problem is whether to invest in the machine, whether to outsource the machine. BERA is costly. OE also cost something. So whether to have your own machine or whether to outsource, because there are many agencies, many centers who actually they bring their own machine or they put their own machine there and they screen your babies. The screening should happen at bedside or it should happen at center. Whether what is better? OE, autoacoustic emission is better or BERA is better? Selection of specialized ENT, timing of screening. District, what is the problem is mindset of parents, mindset of doctors, interpretation, and incomplete loop. So this particular thing will briefly, we won't cover it very at length, just like ROP, the shortage of time. Mainly we'll compare OAE versus BERA. Autoacoustic emission and BERA, there are two different things. Autoacoustic emission tests the cochlear function. It is a simple procedure. It takes less time, 10 to 15 minutes per neonate. More acceptable to caregivers. It is 66% sensitivity and 98% specificity is there. And OE is less expensive. Now here is the catch. Here sensitivity is less. And as we discussed previously, the screening tests must be sensitive. The diagnostic test and screening test, that is the fundamental difference. So OAE, we should know that it is only 2/3 sensitivity. Specificity may be high, but sensitivity is less. So as a screening mode, routine use of OAE may actually sometimes miss many cases. That we have to understand. Now BERA. BERA, recording of brainstem potential to sound, relatively invasive. Takes more time, 30 minutes to 40 minutes. Caregivers feel it is more invasive. gold standard test, but it is more expensive. Now we have to select between two tests, one with less sensitive but easy to perform, and one is actually quite accurate but difficult to perform and more expensive. So how to select between these two? That particular thing will come across. Now, what are the NNF guidelines for newborn hearing screening? Now we know that hearing screening, there are we have to divide into two: well baby and NISU. Now, hearing in well baby, NNF recommends OE or beta. NISU they recommend only beta, because NISU, the sensory neural hearing deficit, is more common because of jaundice, hyperventilation, drugs, aminoglycosides, and all those things, IVH. So NISU routinely using OE is actually likely to actually asking for trouble, because we are going to miss a lot of babies. Opposite to that, well baby, actually OE or beta both can be used depending on the availability. Pass or fail. Once it is failed, 1 or both years, retest prior to discharge. There's 12 hours after OE and several hours after beta. Well baby, retest with the same test or OE or beta, and as you retest with beta. Now, if it fails, rescreen at after 6 weeks. So this is very important, that beta, abnormal beta is very common in preterm babies and SU babies. So we should not make a conclusion based on that. We have to understand the difference. Here what happens, many families don't understand difference between the urgency and need. They said, you only told me to it is important, and once you are seeing the result, you're not giving sufficient importance to it. Because it happens, because in ROP, time is money, and in beta, patience pays. In beta, the hearing assessment, patience pays. Many times if you are patient enough, actually this test becomes quite all right after some time. But in ROP is not like this. So eye and ear should be treated differently. Both should be given equal importance, but the interpretation and urgency is difference in eyes and ears. So if a failed test is there, then we should rescreen after 6 weeks. And at any condition, that evaluation should be completed before baby 6 months old. Because after 6 months old, this one, then there is delay in actually hearing aid and cochlear implants and all those things. So 6 weeks and 6 months, you can remember. If any abnormal test comes up or doubtful test comes up or something, see to it that you repeat after 6 weeks and complete the evaluation before 6 months of age. This one. So newborn screening, same thing happens in many times. Incomplete loop is there. So you should have a system by which you are attached to some hearing center, not ENT surgeon. ENT surgeon is different. Many time ENT surgeon which comes in NISU is airway specialist, but he or she is not actually expert in hearing. So there are specialization in ENT. So those centers who are actually dedicated for this hearing assessment and all those things, we should have tie up with them in metro cities, so that once you screen, once you refer, that particular patient should get the complete care, including cochlear implant. Majority of governments are coming up with this financial support for the cochlear implants. So this one, so we should have a complete, just like ROP, we should have a register for hearing screening, where what happened to the baby, they should be actually aware about it. So far we covered growth screening, we covered ROP and hearing screening. Out of that, this one, we carry home message in growth screening is every baby is different. LGA, AGA, SGA babies, they behave differently. So we should actually go for, we should monitor the baby early and reduce the dropouts. As far as ROP is concerned, selection of ophthalmologist should be based on availability first and then experience. Complementary nature of experience and availability. Avoid drug overdoses in mydriatic drugs, eye drops. So use micro drop technique, use the less concentration, and proper selection of patient, extension of leg, monitoring of the baby to reduce ROP apnea incidence. And hearing assessment screening, main important thing is OE, we should have no limitations of OE, that OE is only 66% sensitive. OE can miss, but OE is available. OE, even if it's available, we are using OE, go ahead with that, but understand limitations. NSU graduates may be missed from OE. And cochlear implant and hearing aids should be available, and that particular tie-up with the center should be actually quite fruitful tie-up. So once you go for this one, then actually all the challenges in urban areas and rural areas can be overcome. So these three things are covered, but most important part, fourth, is metabolic screening, IEMs. So my colleague, he is here, no? Ganesh is here. He will talk a little bit about what are the challenges faced in metabolic screening part. He is not going to talk about metabolic workup and all those things. Screening part, he has got scenarios also, case scenarios, interesting case scenarios, whereby he will tell about the challenges in rural area and challenges in urban area. Please come, Ganesh.
Yeah, thank you, sir. A very good evening to you all. I am Dr. Ganesh. I'm a senior consultant in pediatrics with interest towards inborn errors of metabolism. For the next 10 to 15 minutes, I will talk about the newborn screening test, especially with regards to genetic, endocrine, and metabolic conditions. What are the challenges that we do face in our country when we ask for a newborn screening test with specific regards to the metabolic and the genetic disorders? One, the exact incidence and the prevalence data for these rare diseases are not exactly available. Two, to do a testing ideally on the day 2 or day 3 of life, there are do lot of deliveries that do occur in the hospitals with a large turnover, and few deliveries also do happen in homes. So we may not be ideally do the sampling on day 3 to day 7 of life. In fact, we can reduce it to day 2 to day 3 of life. And especially in home deliveries, we might miss the newborn screening tests. Third, most of these tests are expensive in nature, and there is also a very limited treatment, specific treatment available for this rare disorders. Four, there are very limited number of specialist labs in the country. Even though we collect samples, the transport of samples, the analysis might be difficult. And there are a lot of very few expertise in inborn errors of metabolism available in our country. And for any screening test which fits into the Wilson and the Jugnas criteria, one, the screening test should be an important public health problem. Two, there should be available treatment for this condition. Three, there should be facilities for diagnosis. Fourth, it should be widely accepted by the public. And fifth, the most important, the case finding should be a continuing process and not a once for all project. The next slide. And if you look at the screening test, the screening test which includes the genetic, endocrine, and the metabolic disorders. For the category A, all newborns, ideally they should undergo a hearing screening and test for congenital hypothyroidism. As we all know, it is one of the preventable causes for mental retardation. The screen test for congenital adrenal hyperplasia and G6PD should be done in pockets of high incidence, especially in the north and northeastern parts of our country. The next category is the category B, which includes this screening test should be ideally a high-risk newborn screening profile, which includes like babies who are born to parents of consanguineous marriage, to babies whose elder siblings or elder siblings have been affected, like they might have difficult to control seizures, developmental delay, failure to thrive, or there may be even a neuroregression or a neurometabolic condition, or sometimes an unexplained sibling death. So these group of patients, they just form the high-risk newborn screening category. And the last one is the expanded screening, where we do test for 30 to 40 amino acid disorders, fatty acid disorders, and the organic acid disorders. And this is widely practiced in resource-rich settings. Now, when we are ordering for the newborn screening test, really, what are the challenges that we do face in our day-to-day life, and what are the probable solutions for it? The first thing is, which comes into everyone's mind, is the selection of the appropriate lab. Which lab should I select for sending the samples for doing the metabolic workup? These labs might be located within the city where the person practices, or it may be located in a farther away places. So whenever we are selecting the lab, just look whether the lab is accredited. Two, whether they do the probable routine quality control checks. Three, before sending any sample to the laboratory, it is always necessary to have a conversation with the biochemist or the genetist in the laboratory. Four, look at the possibilities of sample transport, whether the concerned laboratory itself, they can send their persons to our hospital to collect the samples, or is there any tie-up with the courier-based company, or sometimes the families can go themselves and deposit the samples in the laboratory. Five, look at the credit, whether they release the reports in proper time. Six, always send few samples to the laboratory, look at whether the phenotype correlates with the concerned biochemical or the genotype correlation. And we can also ask our experiences from our expert colleagues. So once we based on all this criteria, then we can just select the appropriate laboratory. The next question what comes into everyone's mind is, can we go for an in-house screening test or outsourcing? Most of the screening tests for the genetic and metabolic conditions, they are done by doing a TMS, that is the tandem mass spectrometry, or by a gas chromatography mass spectrometry. These machines are pretty expensive in nature. They need lot of reagents to run the test sample, and it needs a extensive manpower for to feed the sample into the machine, to analyze the data, then interpret the data. And if you do, or if you're going to do each test individually, for example, a G6PD or a thyroid profile, we have to collect different volumes of blood, and it may be quite pretty laborious. So the DBS is widely approved. For amino acidopathies which are detected by doing a TMS, it is always better to confirm it by doing a quantitative estimation of amino acids by HPLC method. For urine organic acids, when we are requesting test analysis, it is ideal to do by a gas chromatography mass spectrometry method. For acyl carnitine profile, either the plasma sample or the DBS sample is widely accepted. So based upon, once we look into all this, it is always outsourcing in a good laboratory is more economical. Third, what is the time? What time should we do the screening test? Most of our obstetric colleagues, they discharge their babies and the patients on day 2 or day 3 of life. This may be because of the high turnover of patients, or it may be because of the obstetric packages. So the ideal timing to do the screening for a metabolic is between 3 to 7 days, but we can limit it to 2 to 3 days. That is, at least after 24 hours of life, the test should be done. And when this DBS screening test comes as positive, it is always better to call the patient, then explain to them, and then do the confirmatory test wherever feasible. Fourth, the most important thing what families are going to ask us, whether it's a newborn screening test, whether it's good to do or bad to do. As any screening test, this test has also got its own advantages and the disadvantages. So the advantages includes: one, we are be able to identify a serious problem which may be treatable even before the baby becomes symptomatic. Two, we can initiate treatment that can prevent serious problems like mental retardation. One of the most example is going to be the congenital hypothyroidism, where abnormal screening test comes positive, do the confirmatory test, and immediately start the treatment for the baby. So this helps to prevent the mental retardation. Or it may help to detect carriers of certain genetic disorders like hemoglobinopathies. The disadvantages are: one, it may fail to identify some children who actually have the condition, that is, false negativities may be there. Two, require repeat testing. So false positives might require repeat testing, or sometimes that repeat testing might be confirmatory test is needed to confirm the diagnosis. During this period of time, yes, there are a lot of stress the family undergoes after coming for a positive screening test, and when the baby is subjected for a confirmatory screening test. The next challenge is, how do we collect and transport samples? Collecting samples, yes, we have to train our nurses for DBS. It is usually the heel prick method, and the ideal collection is the baby's heel should be wiped with an alcohol swab. Then, using a lancet, the heel is pricked. The first drop of blood is wiped out. Subsequently, the drop of blood is collected in the filter paper within the circles that are marked in the filter paper. This is very, very important. There should not be too much of blood so that it forms the cake and the laboratory may not be able to identify anything. Two, there should not be any smudge formation. So these are all essential things what we should carefully look into it. Otherwise, we send the sample and finally the lab asks for a repeated testing. And then once the samples are collected, the most important thing is it should be air dried. For air drying, yes, it should be allowed to air dry on its own. So collect the blood in the filter paper, store it in an air dry, store it in the table or whatever it is for at least 3 to 4 hours so that the blood gets dried up. And we should not pile the DBS papers, and then it has to be transported to the laboratory. Make sure every important detail is filled in the filter paper. Sometimes we do not fill the details and the laboratory may not be able to process it, right? And then when delay in transport is anticipated, the most important thing is it has to be put it in a Ziploc cover and stored in the refrigerated door, right? And then it has to be transported to the lab. So the process is not complete once we send the samples alone. We have to periodically check whether the lab has received the sample, they have processed it, and what happened to the results. And then once the results are available, we have to act accordingly. And in certain conditions, they may even need a repeat testing also. The next important challenge what we face is the inquisition and the anxiety of parents. Parents do ask, doctor, do you think this test is necessary? It charges more. Our baby is healthy. We do not have all any of the high risk conditions what you have told us. But still, do you think it is necessary? Yes, it is necessary, and this can be overcome by providing information about the newborn screening test right from pregnancy. So the best thing is involve our obstetric colleagues. Obstetricians, yes, they have to understand the importance of the newborn screening test, and with every antenatal visit, they have to perpetuate this message to the families so that it becomes very easy for us when we talk about a newborn importance of newborn screening test to this families. And when we doing, yes, we have to explain them about the pros and cons of the test, what is the time frame for the availability of the results, and what we are going to do when the test comes as positive or when the test comes as negative. So this is the newborn screening test. We have to fill all the essential, the DBS card, fill up all the essential data, and the blood has to be impregnated into this 4 circles. Care should be taken that they do not form a smudge or they do not form a cake. And from the tier 2, tier 3 cities, what are the challenges that do we face? One, acceptability by the parents. Yes, there is a lot of difficulty in making the patients convinced to undergo this test. So we have to go for a proper counseling. We have to explain them the pros and cons of the disease and involvement of our obstetric colleagues. The next thing that comes is the cost. So certain laboratories, they have got certain panels of tests, like one panel which may detect hypothyroidism, G6PD, galactosemia. The other panel may include hypothyroidism, G6PD, galactosemia, adrenal hyperplasia, and cystic fibrosis. Other panel might be detecting, so they have got a panel which of about 2 to 3 or 6 to 7 tests or 30 to 40 tests based upon that. So the choosing of the panel, it is with the pediatrician or the neonatologist who is involved in the care of the baby. If you feel any high risk factors are there, please go for a expanded newborn screening test. Right. Third is again the sampling. We have to train the staff to collect the samples in the DBS paper. Again, the storage, transport, follow-up of reports, informing doctors and the families. And in some areas, we do anticipate low turnover of samples. So in that case, the lab may not be willing to transport, or there may not be proper courier services. So to overcome this difficulty, again, we can request from the neighboring hospitals where we can pool the samples by having a proper MOU with them. And interpretation, sometimes in difficult cases, we can always take help from the expert colleagues. And the treatment might be in the local facility. For example, congenital hypothyroidism, where we can start treatment in the at the area of diagnosis itself, or for babies who are very sick, they can be transferred to the appropriate centers. So going to the few case scenarios of this newborn screening test. This is a 3-day-old boy who was born to third-degree consanguineous parents. He had history of 2 sibling deaths in the neonatal period, and he was born by LSCS, term baby with a birth weight of 2.75 kgs, cried after birth, initiated breastfeeding, and shifted to mother's side. On day 7, this baby did not undergo a newborn screening test. On day 7 of life, he presented with tachypnea, convulsions, and hypoglycemia, and he was referred to us for further evaluation and management. His baseline counts were normal and CRP is negative, so probable sepsis has been ruled out. When we looked into the metabolic results, there is low glucose, high ammonia, acidosis, and there is no ketonuria. So this is a pattern recognition for a fatty acid oxidation disorder. He was treated with IV fluid, sodium benzoate, IV carnitine, and antibiotics. On day 9, he developed refractory shock, metabolic acidosis, and he finally succumbed with the diagnosis of a fatty acid oxidation disorder and Klebsiella sepsis. His metabolic profile, what he has sent us, showed increased levels of C8, C10, and urine for organic acid showed dicarboxylic aciduria, and his genetic studies confirmed it was a medium chain acyl-CoA dehydrate deficiency. So what we have learned from this baby: one, this baby did not undergo a newborn screening test. Two, especially in babies, especially in families who have this high risk factors, especially loss of two babies in the newborn period, should have prompted more to go for a high risk newborn screening test. So this forms very, very important here. Going to the second case scenario, this is a 3-day-old male baby who was born to second-degree consanguineous parents. It's a G3P1A1L1 mother. antenatal period was uneventful. He was born at term with a good birth weight of 2.8 kilos, cried at birth. Elder sibling was 10 years old, boy normal. So uh, his newborn screening test at discharge from the hospital for this panel, galactosemia, cystic fibrosis, G6PD, CH, and hypothyroid came as normal. But he was admitted on day 3 to day 4 of life with lethargy, poor oral intake, and reduced urine output. So at examination itself, he was sick looking, encephalopathic, hypotonic, acidotic breathing, and he was hypotensive. His count showed a leukocytosis. When we looked into the metabolic profile, he had hypoglycemia, very high ammonia levels with severe metabolic acidosis, and there was ketonuria. So this is a pattern recognition for an organic acidemia, right? And he was treated with sodium benzoate, dialysis, even including the hemodialysis. But in spite of this, he could not be revived. So this baby, if you look into the history, born to consanguineous parents, have undergone a routine newborn screening profile, which came as normal, but is the extended panel was not done, or the high risk panel for amino acids, acyl carnitine, and urine organic acids was not done, and he had a diagnosis of a methylmalonic acidemia. We did a genetic mutation testing report, which came posthumously showed a mutation in the MUT gene, and both his parents were carriers for the same. But they have a baby who is the elder baby who is normal. So this is a moving to the third case. This is a 10-day-old baby girl. He is first born to non-consanguineous parents. He was born at term and said to cried at birth and discharged on day 3 of life. So newborn screening test at discharge came positive for galactosemia. His total galactose levels was 18 milligram per deciliter. Normal lab reference range was below 15 milligram per deciliter. So he was advised stopping of breast milk, was on soy-based formula, and referred for further management. So on examination at day 12 of life, he was thriving well. He looked alert. There was no jaundice, no cataract, no hepatomegaly, and his neurological examination was normal. So further workup we did. So these parents were very anxious whether this baby has got a galactosemia or not. So we did a further workup. For his urine, non-glucose reducing substance came as negative. His blood sugar levels were normal, and his plasma total galactose 1-phosphate, transferase, and epimerase, everything was within normal limits. So as you all know, galactosemia is caused by deficiency of galactose 1-phosphate uridyl transferase enzyme, or a galactokinase enzyme, or an epimerase enzyme. So with this, comparing with this biochemical parameters, so he did not fit into anything, and he was reassured that he did not have the underlying problem, and mom was advised to restart breastfeeds, and at 8 months of follow-up he is perfectly well and is neurologically normal. So what the lessons we learned? So a newborn screening test comes as positive. So it doesn't mean that always the baby has got an underlying disorder. It is very essential for us to go back, obtain the history, perform a thorough clinical examination, and do the confirmatory examination. So confirmatory examination includes ordering for specific and confirmatory tests, including the molecular genetic testing. And it doesn't stop here. It always requires about the follow-up of the baby on a long-term basis to establish whether he has got a disease or not. So with this, I conclude my talk on this newborn screening test. Yes, it's very, very essential for newborn babies to undergo a screening test for genetic, metabolic, and endocrine disorders. The profile choosage can be to the discretion of the treating clinician, and positive screening test always needs to be followed up, and negative screening test doesn't mean that the baby is perfectly normal. Again, these babies have to be followed up on a long-term basis. Thank you.
Thank you very much, sir. So we will take up the question after this talk. Over to you, Dr. Nilesh. Dr. Nilesh, thank you very much, sir. It was a wonderful session. We will have discussion session after this talk. Dr. Nilesh?
Yes.
Yes, over to you.
Can you see the screen, Prashant?
No, yeah.
Now can you?
We can see, yeah.
Hello, everybody. Good evening. I'm talking. My talk is on inborn errors of metabolism in neonates and infants. So the objectives of this talk are to give an outline about inborn errors of metabolism. Just a minute. Can you see me? Can you hear me?
Yeah. Please go ahead.
So to give an outline about inborn errors of metabolism in neonates and infants, and also to touch upon the clinical features and investigations and general management. So the detailed discussion about each disorder is out of the scope of this talk. So how do we define an inborn error of metabolism? So these are heterogeneous group of disorders in which a single gene defect may lead to a metabolic pathway block, which either causes substrate accumulation or deficiency. This may lead to a wide array of clinical symptoms. So although compared to other diagnoses in neonatology, these group of disorders are rare, but collectively, if we look at them, they are numerous. So if you look at Indian data, so this is from Dr. Anil Jalan's data, there are around 20,800 births per year in India with metabolic diseases. Now, we all know that rapid diagnosis is paramount. So why is it so important? So instituting rapid treatment may make the difference between life and death, or also like survival with good neurodevelopmental outcome for newborns. So rapid diagnosis is also important for prognostication because there is extensive knowledge about all these conditions now. And if there is a neonatal death, also for genetic counseling in future pregnancies. Now the picture at the bottom, we can see precursor A turns to substrate B, and which in turn forms product C. If you see EA and EB, EAB, beta and EBC, these are enzymes that catalyze the reactions. If there is a block with EBC, you can see that substrate B accumulates and also toxic metabolite D, which may have harmful effects. Sorry. So what are, how do we suspect an inborn error of metabolism? So there are certain symptoms where you'll have to keep in mind inborn errors of metabolism. So persistent unexplained symptoms after ruling out commoner etiologies in the NICU. And also we should have a high index of suspicion when there is first or second degree consanguinity. And the symptom onset is after 1 or 2 days after starting feeds. Unusual urine odor, if there is ketoacidosis or if there is recurrent hypoglycemia. Also, we should be careful when there is a family history of sudden death or previous neonatal death. Whenever there is a constellation of unexplained symptoms or unexplained neonatal death, we may have to consider an inborn error of metabolism because there may be disorders that may have not yet been delineated or defined. So in acutely unwell neonates, where you have covered for sepsis and all the usual management line, we should also consider inborn error of metabolism. It is very important or crucial that we never miss a treatable disorder. Now, most of the inborn errors of metabolism are inherited in an autosomal recessive way. But there are some exceptions like ornithine transcarbamylase deficiency, Menkes, Hunters and all, where there is an X-linked inheritance. The incidence of inborn errors of metabolism, again, Indian data, whenever we think about IEMs, the picture of urea cycle defects comes to our mind. But the data here also shows that there are other disorders like organic acidemia and mitochondrial disorders and amino acidopathies where the incidence is even more than urea cycle defects. So each country, probably the incidence varies. Sorry. Now, there is a classification of inborn errors of metabolism based on pathophysiology. So group 1 is disorders of intoxication, wherein small molecules of intermediary metabolism, there is a block of the pathway leading to accumulation of toxic metabolites. Now, intermediary metabolism involves all sorts of pathways involving carbohydrate, fat, and protein, where the catabolic, anabolic processes are involved. Now, what are the disorders we typically see in this category? So one is amino acid metabolism errors, organic acidureas, urea cycle defects, sugar intolerance disorders like hereditary fructose intolerance, metal intoxication, porphyrias, and also neurotransmitter errors like non-ketotic hyperglycinemia. So these disorders, as a general rule, do not interfere with embryo-fetal development. So they do not cause dysmorphism or dysplasia. There are typically acute or chronic intoxication signs, maybe the manifestation. Acute is vomiting, baby goes to coma, liver failure, thrombotic episodes and all, or there are chronic manifestations. Typically, these are episodic, and there is a symptom-free interval that precedes the onset of these. And also, these disorders are precipitated typically by catabolic stress like fever, fasting, and intercurrent infections. So the treatment involves emergency removal of the toxins. First is to cut the toxins, so reduce the substrate and remove it. So through hemodialysis or peritoneal dialysis or other cofactors, etc. The second group is disorders of energy metabolism due to deficiency of energy production or utilization in the major organs like liver, heart, muscle, and brain. So there are two categories. One is the mitochondrial disorders, which encompasses congenital lactic acidemias, respiratory chain disorders, fatty acid oxidation disorders, and ketone body metabolism. Here, there may be embryo-fetal development issues. These may cause dysmorphism, dysplasias, and malformation in the neonate. There are cytoplasmic energy defects, which are basically glycolysis and glycogenolysis, hyperinsulinism, creatine and pentose phosphate pathway. The symptoms include low sugar, high lactates, and organomegaly like hepatomegaly, low tone hypotonia, cardiomyopathy, and sudden unexpected death and even failure to thrive. These group of disorders, it is little more difficult to diagnose. So enzyme assays may be useful, function tests, and typically molecular genetic methods, but most of them are not treatable. Now the third group is disorders of complex molecules that involves cellular organelles like mitochondria, peroxisomes, Golgi apparatus, and endoplasmic reticulum. So here the symptoms are more insidious, but they may be permanent and progressive. So the examples are lysosomal disorders, peroxisomal disorders, congenital disorders of glycosylation, cholesterol synthesis disorders, and alpha-1 antitrypsin. So diagnosis is mainly by DNA analysis. Very few are treatable. Although for some lysosomal disorders like Pompe's, enzyme replacement therapy may be available. Now, what are the symptoms? So we know that in neonates, there is a limited repertoire of symptoms. So most of these include poor sucking, hypotonia, respiratory distress, vomiting, diarrhea, lethargy, seizures. All of these are seen in all kinds of disorders. This is a common pathway. What are the differentials? So most common or the most misdiagnosed is sepsis. And we know that many of the babies whom we are culture negative and the baby dies may possibly be an inborn error of metabolism. Hypoxic ischemic encephalopathy is the other diagnosis. Duct-dependent cardiac lesions may cause collapse on day 3 to 4. Congenital adrenal hyperplasia, congenital infections, and dyselectrolemia. Now, what are the patterns of presentation in inborn errors of metabolism? One is a major mode of presentation is neurological. That is encephalopathy with or without metabolic acidosis. So these are mainly related to organic acidemias, where there may be hypotonia and myoclonus, and also maple syrup urine disease, which usually presents with hypertonia, opisthotonos, and peddling, and urea cycle defects. Now, hypotonia is a prominent feature in urea cycle defects and mitochondrial defects, non-ketotic hypoglycemia, hyperglycinemia, and sulfite oxidase and peroxisomal disorders. Intractable seizures may be a presenting sign in pyridoxine dependency, NKH, folinic acid responsive seizures, and molybdenum cofactor deficiency. There may be a hepatic presentation with hepatomegaly, seizures, and hypoglycemia, the glycogen storage disorders, and gluconeogenesis. Hepatic failure in the first week of life. So one is neonatal hemochromatosis, and these are the syndromes that come under GALD. And then galactosemia, hereditary fructose intolerance, tyrosinemia type 1, and mitochondrial disorders. We had a recent baby in our unit who was fitting in the clinical profile of neonatal hemochromatosis. So the baby unfortunately passed away. So we had investigated with ferritin and all sorts of investigations, including MRI. Now, cholestasis is a presenting feature in mitochondrial or fatty acid oxidation disorders, bile acid disorders, and alpha-1 antitrypsin. Now, storage disorders we all know, GM1 gangliosidosis and Niemann-Pick type A. Cardiac presentation is a major pattern in fatty acid oxidation disorders, where there may be hypotonia and cardiomyopathy. There may be high lactates in congenital lactic acidosis, and cardiomyopathy may be seen in propionic acidemia and LCHAD, long chain hydroxyacyl dehydrogenase deficiency. Now, dysmorphic features are a part of peroxisomal disorders like Zellweger's and pyruvate dehydrogenase deficiency. If we also look at the abnormal urine or body or odors, we know that burnt sugar is MSUD, sweaty feet is isovaleric acidemia, fishy is described in tyrosinemia, and mousy in phenylketonuria. Now, what are the clinical pointers for suspicion of inborn errors of metabolism? So if there is a rapid deterioration after a normal period, if there is parental consanguinity, family history of deaths, any rapidly progressive encephalopathy with recurrent seizures, any unexplained severe metabolic acidosis, persistent vomiting in newborns, or any kind of odors of the urine or body fluids. Also, an antenatal cause. So the LCHAD may present with acute fatty liver or HELP syndrome in the mother. Now, these are a few findings, like cause facies may be seen in lysosomal disorders, cataract may be seen in galactosemia and Zellweger, and eczema, seizures, and alopecia may be seen in biotinase deficiency. So we're going on to a quick case. So there was a term baby who was born to a elderly primate who is 42 years old, multiple failed IVF cycles, and the father was 45 years old. The father had sperm motility issues. Now, it is interesting to note that many mitochondrial disorders, even carriers, may have sperm motility issues. So this was a spontaneous consumption very late when the mother was 42 years old. Everything was uneventful. The baby was fine, transferred to mother's side. At 22 hours of life, was found unresponsive in the ward and transferred to the NICU. Resuscitated, maximal resuscitation, nothing could be done. The baby did not survive. Now, these were parents who were like highly educated PhDs in science, both of them. So they wanted a complete investigation. Now, here we did cover for sepsis, and most of the septic parameters or the tests were negative. There was severe cardiomyopathy in the echo when the baby was brought down to the NICU, and very poor cardiac function. There was a high anion gap metabolic acidosis, as you can see. And the blood glucose was normal. The ammonia, plasma ammonia, was very high, and the lactate was also high. So there was lactic acidosis with high ammonia levels, and cardiomyopathy with a normal sugar. So finally, I'll skip some slides, and the Guthrie was not conclusive, but we went on for acyl carnitine analysis by TMS. We found this profile, so that it was abnormal for acyl carnitines. And finally, we ended up, after kind of shortlisting a few, these were the final differentials, so glutaric aciduria type 2 and fatty acid oxidation disorders. So the final diagnosis by clinical exome sequencing, there was a mutation in which was found out to be acyl carnitine translocase deficiency. So essentially a transporter that transports very long chain fatty acids into and outside the mitochondria, leading on to low carnitines and sudden infant death kind of a syndrome. Now, approach to a neonate with suspected inborn error of metabolism. So the first test to do is the ammonia level, and also we do a blood gas, like an arterial blood gas. Now, if you look at the extreme left, the ammonia, if there is a high ammonia, high ammonia level with no acidosis and no ketosis, like urine ketones are normal, then it may suggest a urea cycle defect. So if there is acidosis with high ammonia, there is if the urine ketones are negative, there is a possibility of fatty acid oxidation disorders. Again, ammonia is normal, but there is acidosis and there is no ketosis. Again, there is a possibility. So fatty acid oxidation disorders, either the ammonia may be normal or high. And organic acidemias and mitochondrial disorders, there may be a normal ammonia and metabolic acidosis, including lactic acidosis. Now, urea cycle disorders are a group of disorders of protein catabolism where high ammonia levels occur because of blocks at different levels. Now, a neonate typically presents on the second or third day with lethargy, and also there is a characteristic respiratory alkalosis because ammonia stimulates the respiration. Most of the newborn presentations are specifically related to ornithine transcarbamylase deficiency or arginosuccinic acidemia or citrullinemia. So we essentially look at the plasma citrulline levels and also at the arginine levels and the urine orotic acid. So a urine orotic acid, if it is positive, it indicates OTC deficiency. Now this is another diagnostic anagram that is used for emergency management. So here it's slightly different. So here we look at the metabolic acidosis or the arterial blood gas first. And if you look at the panel on the extreme left, we can see that there is high anion gap metabolic acidosis. The sugar is normal, high ammonia levels. There is lactic acidosis, and there is ketosis. The urine ketones are high. So this indicates organic acidemias like methylmalonic and propionic or isovaleric. And the sugar is normal, ammonia normal or high, very high lactates, and the ketones may be normal or high. Here you can do the lactate pyruvate ratio. So again, the respiratory chain disorders. So this is a good graph, I think, just to kind of categorize into broad categories. And the third one is low sugar, high ammonia, normal lactates, and low ketones. So again, fatty acid oxidation disorders. You should remember that the urine ketones are absent typically in fatty acid oxidation disorders. Now, if there is no acidosis and everything is normal, but ketosis may or not be present with ketoaciduria and severe neurological manifestations, then you should think about maple syrup urine disease, which is very common or kind of relatively common in newborns. Now, if everything is, all the tests are normal, then we go on for CSF analysis, where we see a baby presenting with recurrent seizures and persistent hiccups, non-ketotic hyperglycemia, and phytoxidase deficiency. Now, urea cycle defects, the acidosis is not there, but ammonia levels may be very high. And there are, now there is a diagnostic approach in small molecular disease. It is categorized into group 1, 2, 3. So here again, it helps to delineate between the disorders. So if you have a baby and you have done the investigations, these I'm not going to was one example of SIDS. So typically fatty acid oxidation disorders and ketogenesis disorders. So like the medium chain acyl-CoA dehydrogenase and L-CHAD, and also carnitine disorders are common. In urea cycle disorders, OTC deficiency is a cause of SIDS in the newborn, and all sorts of organic acid ureas like propionic acid urea or methylmalonic can present with SIDS. Congenital lactic acidosis encompasses a group with pyruvate dehydrogenase deficiency and also pyruvate decarboxylase deficiency. These can present. And certain disorders like galactosemia, GSD1, and hereditary fructose intolerance may present with SIDS. Now, what are the first line investigations? So complete blood count. We know that the organic acidemias may have neutropenia and thrombocytopenia. Of course, ABG and electrolytes. So many of these babies present in with severe dehydration. So electrolytes is important. Blood glucose, because recurrent hypoglycemia may be common in mitochondrial or fatty acid oxidation disorders. Plasma ammonia levels. So the normal levels are like 90 to 150 microgram per deciliter, or 64 to around 110 micromole per liter. Now, when we look at urea cycle disorders, the range we are talking about is like 500 to 1500 micromole per liter. So if it is more than 200, we have to be. Now, blood lactates, 0.5 to 1.6 millimoles per liter. So anything less than 2 is normal. Liver function tests, urine ketones, and reducing substance. Of course, serum uric acid may be in molybdenum cofactor deficiency or GSD type 1. Now, urine ketone body is positive is seen in organic acidemias and gluconeogenesis and glycogen storage disorders. Now, urine ketone body is negative. We talked about fatty acid oxidation disorders. We also know that hyperinsulinism causes lack of ketone bodies in the urine. So, ketogenesis defects can also cause. What are the second line investigations? So something that has revolutionized the diagnosis of inborn errors of metabolism is tandem mass spectrometry, where two spectrometers are in line, and this helps in the plasma amino acid and acyl carnitine analysis. So this is used in organic acidemias, urea cycle defect, amino acidopathies, and fatty acid oxidation disorders. Now, if there are volatile compounds in the disorder, then we also have gas chromatography and mass spectrometry of the urine. This is one of the tests which combines the best of two tests. So gas chromatography separates the volatile compounds, and then mass spectrometry identifies the compound. So organic acidemias and many other disorders, we do GCMS of the urine. Now, for quantitative analysis, for more in-depth analysis, we do high-performance liquid chromatography. Other investigations are like enzyme assays for biotinase deficiency and GALT for galactosemia. Now, imaging in metabolism, there are many findings. So, findings may be seen in maple syrup use in organic acidemias. And this is essentially edema and changes in the basal ganglia. Agenesis of corpus callosum may be seen in non-ketotic hyperglycemia and pyruvate decarboxylase deficiency. Zellweger, they may present with dysmorphism and migration defects. And also MR spectroscopy may be useful in the diagnosis of mitochondrial disorders, NKH, and maple syrup urine disease. EEG is another investigation. So you can see a burst suppression pattern where the brain is injured in NKH and a comb-like pattern in MSUD. Other tests are urinary orotic acid in urea cycle defects, lactate pyruvate ratio, plasma very long chain fatty acids in Zellweger syndrome, and CSF amino acid analysis. Now, there is a protocol for emergency investigations. So this also details the collection samples that we have to collect. So around 15 ml of urine is what we usually collect. So all the tests that we previously described, and also in the blood, these are the tests. Now around 5 ml of plasma and blood on filter paper, 2 or 3 filter papers, and whole blood. So what we typically send is a heparinized sample, typically 2 to 5 ml, and EDTA sample, and then plasma, and then urine around 15 to 20 ml. This is, and with some dried blood spots too. So this is what we send to Mumbai for analysis. Now, what are the basic principles of treatment? So basic principles, these are the major principles. So reduce intake of the substrate and thus limit formation of metabolites, and provide adequate calories to prevent catabolism, because many like organic acidemias may worsen if there is a catabolic state. Enhance the excretion of toxic substances. Supportive care that includes preventing dehydration, ventilation, and correcting electrolyte disturbances, and empirical cofactor therapy, and of course specific therapy. Now, hyperammonemia, what do we do? So we discontinue feeds so the protein source goes. This is the acute phase management. Also provide adequate calories with glucose with a GIR of around 8 to 10 milligram per kilogram per minute. And lipids can be started at like 0.5 to 1 and increased to 3 gram. Now, hemodialysis is typically better than peritoneal dialysis to remove ammonia, and exchange transfusion is typically not useful. But practically, whatever we or whichever cases we have managed with peritoneal dialysis. So we had we had a case who had very high ammonia levels, and the most of the features were fitting into the HHH syndrome, which interestingly later the child recovered neurologically, was completely normal, and retrospectively looking at it, it looks like a transient hyperammonemia of the newborn. So here we have the treatment includes use of sodium benzoate, sodium phenyl butyrate, and L-arginine and L-carnitine. So what the principle of using these is to form products that go out in the urine, like glycine and formation of hippurate and those sort of mechanisms. Now, management of organic asthenias. So again, the child is kept NPO for 48 hours, and IV fluids with glucose are given. And if there is a severe acidosis, sodium bicarbonate correction may be given. Dehydration should be corrected. Most of these neonates present with dehydration, and sepsis is treated because of, as we know, they have leukopenia and thrombocytopenia. Many of them, if the child is lethargic, may require ventilation and also treatment for hyperammonemia as previously described. Carnitine is an important component. Almost 100 milligram per kilogram per day can be given here. Glycine can be used in isovaleric acidemia. Also, the multivitamin cocktail can be used in organic asthenias, vitamin B12, thiamine, and biotin. Management of congenital lactic acidosis. This includes disorders involving the respiratory chain. So again, supportive care. Thiamine is useful here, and very high doses up to 1000 milligram per day may be useful in pyruvate dehydrogenase deficiency. Riboflavin and L-carnitine. Now, treatment of acidosis is another pillar of management. Fatty acid oxidation defects. The glucose glucose provision should be high, around 10 to 12 milligram per kilogram per minute. Carnitine and fasting should be prevented. So if you look at long-term management, older infants may develop hypoglycemia late in the night because of prolonged fasting. So they may benefit with uncooked cornstarch. And of course, medium chain triglyceride supplementation, because there is a direct absorption of 2 to 3 per kilogram may be required initially. Now, these days, there is some literature on the use of DHA supplementation in these disorders. Now, refractory seizures, pyridoxine trial is given, and if IV is not available, oral can be given. If seizures persist, biotin and folinic acid should be added, and also a trial of pyridoxal phosphate. It's also prudent to rule out a glucose transporter defect because it is a treatable condition, and improvement happens with a ketogenic diet. GLUT1 deficiency. Now, cofactor therapy is useful. Again, thiamine, riboflavin, pyridoxine, cobalamin, folinic acid, and biotin. It's a busy slide. In the interest of time, I'm going to skip the slide. Of course, this talk will be available. So if anyone wants, I think useful in inborn errors of fatty acid oxidosis and organic acidemias, tyrosinemia type 1, Wilson's disease may benefit with liver transplantation. There are some centers in India where it is done. Of course, the prognosis is guarded. Also, it is possible in chronic liver disorder like alpha-1 antitrypsin deficiency, GSD type 4, tyrosinemia, and Wilson's disease. So, inborn errors are chronic or a heterogeneous group of disorders involving single gene disorders with protein or diagnosis is extremely important for good survival and good neurodevelopment outcomes in babies, and also for prognostication, and also for future pregnancies. Lots of treatments are available, but initial stabilization is extremely important, especially in the intoxication category of inborn errors of metabolism. I'd like to thank Dr. Arvind Shanai and all my colleagues for preparing the talk. I think I'll stop here. I had a few slides on a few other cases, but in the interest of time, I'm not presenting them. Over to Prashant.
Yeah, thank you, Dr. Nilesh. Yeah. Good, sir.
Hello?
Hello.
Hello?
Kishore, yes, sir, we can hear you. Hello.
Hello, good. You finished on time. I think for future speakers, Prashant, you have to be very strict and to be maintained webinar, because normally a lecture is 20 minutes maximum. You can go for 30 minutes. People take 1 hour. The second speaker will be 30, and then we won't be able to hear the lecture. Interest of the time, we did a job and thing. I think now we will open the session for questions.
Dinakar sir, is there any questions from Facebook and YouTube, sir?
At present, no.
Okay. Somebody has raised the hands.
Myself, Dr. Naresh Prasad from Dhanbad.
Yeah.
Sir, can we diagnose this condition of inborn error of metabolism in the antenatal period? Do you have any screening studies about them? And if it is yes, answer is yes, what should be the gestational age of that?
Sir, can you repeat the question, sir? It was not very clear. Can you repeat the question a little slowly, sir?
Can we have the screening program against the inborn error of metabolism in the antenatal period? And can we diagnose this condition antenatally? And if
Is that for me?
Yeah, any one of you can take, Rahul sir or
No.
Nilesh.
Nilesh.
I think typically whenever we have disorders, we involve the genetic counselor. We had a recent meeting. So second trimester and do a genetic analysis on that, especially if we know the mutation. Like for this disorder, we had a clinical exome showing carnitine acyl CoA translocase. So and it looks like both parents were carriers. So those sort of things is what it needs a lot of coordination. Like, you know, the parents, the obstetrician should be kept in the loop. They typically have a relationship with the obstetrician, and we involve the geneticist and genetic counselor.
Sir, what is the cost of this screening test and the best laboratory which is available in India, and how often we have to repeat the test?
It depends on which disorder. So these kind of clinical exome and whole genome sequencing are extremely expensive. Typically 30,000 or 20 to 30,000. It depends on each disorder. So it's variable.
So out of all these conditions we have discussed right now, out of which what are the conditions we have got the good prognosis?
So I think most of these disorders, especially the intoxication type, the urea cycle disorders and all have a good prognosis. And lots of essential formulas are available. So there is one pristine group, pristine pharmaceuticals, and all pharma companies have formulas. So most of these have good prognosis, but some like organic and other disorders like mitochondrial disorders. Those sort of things have a bad prognosis. So it's a huge group of disorders. So I'm just giving you one or two examples. So in the general pattern is like if you have a diagnosis, it makes a huge change. If you can exclude the that substrate, and if you have most of the urea cycle disorders like MSUD, amino acidopathies, you have formula which may have a good long-term outcome.
Sir, do you think these cases, once these are diagnosed, can be treated at the peripheral level or district level, or it should be instantly referred to the higher center?
The more complex it is, I think it's better to refer at the to higher levels. But I think the management, when you make diagnosis, and then NBS is available now, I think everywhere. So management, you don't need to delay, but probably the further investigations for the next pregnancy, it may be better in a city like Bangalore. I don't know, Dr. Rahul can probably comment on that.
No. As far as prognosis is concerned, I think there is time has come to change our mindset. Because predominantly majority in India, once IEM is mentioned, they actually go for a negative mindset. This particular situation is changing rapidly because of availability. As you pointed out, a lot of formulas are available, special formula, diagnosis is better. So as far as this prognosis is concerned, prognosis depends on management more. So as our management is getting more and more refined, the prognosis is rapidly improving. So as far as this periphery and center is concerned, this periphery main problem is delayed diagnosis. So diagnosis should be timely, and there should be timely consultation with metabolic expert. This metabolic, there are some people who know, because IEM is a condition, either you know or you don't know. There is no in between. So people who know metabolic error, the person should talk in actually immediately, and depending on his guidance, he should decide how to manage and how to refer.
Thank you, sir. Thank you very much.
Thank you.
Thank you.
Vichu had raised the hands. Yeah, I think there is one question. What is the sir, Kishore sir?
Yeah.
Any questions to you, sir?
No, I don't. What is the probability of a false negative report with the TMS, filter paper test? Somebody has asked the question. What is the probability of the false negative report with the TMS? Nilesh, can you answer that?
I'll probably pass that to Dr. Ganesh or Dr. Rahul. Ganesh is the expert at false negative.
He is there. Ganesh is there. Ganesh is gone. Just ask. So as this false, this we are suffering from metabolic error. Clinically, it was looking like a metabolic error, and the workup came negative. Because of that, many times we feel that the lab is not accurate. The question is actually, the main problem happens in the disease, but the lack of correlation happens. So again, I repeat that whenever you are sending a test investigation, we should have a complete clinical picture of that particular thing. I mean, that particular should be guided by somebody who is expert in that. So somebody who is an expert in IEM, they are present in almost all metro cities. For example, me, as far as I'm concerned, I try to understand metabolic error, but I came to know that I was not able to understand metabolic errors. So whenever I suspect metabolic error, I usually call a person who knows about metabolic error, and I take feedback from him. So as far as this metabolic error is concerned, immediately we have to ask somebody who is knowledgeable about this metabolic error. We should not hesitate. We should not put our ego there, and we should, in accordance to that, we have to go for workup of the case. Suppose test comes negative, then immediately we have to inform again. I'll just give one example. Recently, we got a case from Madurai. So this baby, actually, all these TMS tests were done, ammonia was done, everything was normal. And baby was having burst suppression pattern. Baby was completely comatose. Baby was completely dependent on ventilator. He was declared as a brain dead. This baby came, and we observed. When we went through the report, we came to know that this burst suppression pattern may be because of NKH. And this baby worked up on NKH, and NKH actually turned out to be actually the diagnosis. Baby came out of ventilator and completely on full feed, and he's going home on special formula. So so-called brain dead baby also can go home on special formula if the expert person is involved. So I would like to repeat again and again that every city has got at least 4 to 5 people who are actually taking interest in this metabolic error diagnosis and all those things. Those people have to encourage and where to take their opinion at correct time.
Sir, there is a family stay in which the parents are having 2 girl child surviving and doing very well, but the 1 male child died within the first week, within the early part of the neonatal period, and the second child is also died recently
Yes,
within the 3 of also, first 7 days of life.
yes, sir. So here is the most important part. Here is this particular couple. So in this particular case, this particular baby couple should be actually taken into this one, and the how the died first and second, whether it be a congenital cause, genetic cause, or acquired cause. That should be actually first up or streamlined. Many times we get cases where the IM is suspected because of previous, but actually on taking history, we come to know it is plain sepsis or congenital heart disease, or it may be actually birth trauma, or it may be HIE, or it may be cold stress, hypernatremic dehydration. So a detailed history should be taken, and based on that history, we should analyze the probability of each, and depending on that, we have to investigate rather than again doing amniocentesis. Again, we do amniocentesis. Right now, we don't have diagnosis, so we don't have genetic diagnosis. So amniocentesis is not going to be helpful in this case. So this particular situation, we should go for verbal autopsy, detailed history taking by a team of people, including OGCN, including neonatologist, and including IEM expert. All 3 people should take detailed history and then come to conclusion what threat to pursue.
What can be the lethal genetic condition for this type of history?
I don't know. Unless until we find out the cause, detailed history. Without detailed history, there is no, the guess should not be done as far as cause of death to be found. So detailed history must be taken right from conception to death in both cases, week by week, and going through the case record. And after that only we'll come to know whether IM is possible or not, which type of IM is possible, what type of breathing was there, what are the fetal movements, what are the Apgar scores. Everything should be detailed analysis should be done. After that, we'll come to know about that.
Thank you, sir. Thank you.
Yeah. If anybody has doubt, they can raise the hands. We'll unmute them.
If there are no further questions, I really wanted to thank Rahul and Ganesh and Nilesh. Rahul, your lecture was very practical, very day-to-day problems, especially in the rural and urban areas. And it's not something anybody can find in a textbook. Very point to the practical pediatrics, very, very useful. Ganesh, you highlighted all the metabolic disorders. And Nilesh, you really highlighted how to approach on case-based scenarios and the complications and various complicated treatments. So it was a very, very big eye-opener to all the practicing pediatricians, very practical approach.
So there are people who have raised their hands, sir. One, Kotreshi, sir.
Hello, sir. Like Dr. Kishore Kumar said is very right words, and we are lucky of having a Dr. Nilesh and Dr. Rahul, all a wonderful subject, and especially the things change in the very at the city level also. The basic like investigation, everything, and clinical also very much impressive. And I'm very much thankful for both the speakers on behalf of KNF. Thank you, sir.
Thank you, sir.
Yeah, and there is one more person, Tanveer Begum. Is there any question?
Yes, sir. Good morning. Good evening, sir.
Good evening. Yeah.
Sir, we are having a child about 15 months old, sir, admitted in your unit with repeated hypoglycemic attacks, sir. This child was admitted at periphery and he is having documented hypoglycemia since birth. He is having the history of NICU admission for about 10 to 12 days, sir. So we have done the TMS once, sir, that came out to be negative. We have sent the TMS again. We are suspecting.
One second. Yeah. 1 second. She got unmuted one.
Dr. Nilesh, I have sent one message to you. Somebody has from question to you. We are waiting for your answer.
Sir, for this first TMS was negative, sir, for our case. Again, we have sent the TMS, sir. The child is having repeated attacks of hypoglycemia, sir. Whenever we increase the GIR, it is maintaining the euglycemic levels. Once we come down, but there is no ketosis, sir. We have checked the ketone levels are negative. We are waiting for the TMS report, sir. Can we do something else in this case, sir? Sir?
So typically, this hypoglycemia, we like you told, I think, did you check with another lab or so, the TMS? And of course, this glycogen storage disorders are the next line of investigation. And other disorders like, you know, the 6-bis phosphatase and phosphate.
We have sent the test for repeat analysis.
In the periphery, or where are you? Correct.
We are from Guntur, Andhra Pradesh. I'm in postgraduate,
Okay.
sir. From in our hospital, we are having this case, sir. It's about 1 week since admission, sir. We are having documented hypoglycemic attacks, sir. Jesus.
So I think the TMS, of course, galactosemia and all you are ruled out, and even
reducing substance negative, sir, and ketones is negative, sir.
The fatty acid oxidation disorders are the other probability, but again, I think we will get something on the TMS again.
Yes, sir. And we have to wait for that report only, no, sir.
So, and then pursue a line of this one investigation for you know, glycogen storage disorders.
Yes.
We've done uric acid levels now.
And today itself we have sent it, sir, to rule out plaque. Today we sent waiting for the reports.
Those sort of things.
Can I add something? Because what happens in this situation is usually when a metabolic error is suspected, we usually go by piecemeal approach, because the descriptions in books are like flow charts. Do first blood gas, then then ammonia, then pH, then Manon gap, and all those things.
Yes, sir. We have done
what I want to convey is this particular flow chart approach is for paper. This flowchart approach is for interpretation. It is not meant for actually doing investigations. So majority of times what we do is we do one test. We eagerly await for the test. That test is not conclusive. Again we go for next test. Again that is not conclusive. And by the time actually patient get actually worsened. So what I suggest is, in case of causes of hypoglycemia at this particular age, just find out what are the causes, what are the tests done, and we can do the test actually immediately, all including insulin, galactose. So all the tests should be done at one time, and when interpretation time comes up, then flowchart should be used. The flowcharts are not there to actually use the test piecemeal, because once you send the test, at least 1 week goes in getting the result itself. So every week we keep on postponing the diagnosis. So
yes, sir. We have done the ABG, sir. Only mild acidosis was present, sir. Serum ammonia is normal, sir.
How is insulin level?
Insulin level is also within normal limits, sir. I don't remember the exact number. Only one thing is serum 8 AM cortisol was low once, sir.
Correct.
We want to do that also, sir.
Correct. So what I mean to say, not only for hypoglycemia, for everything, whatever possibilities there, we have to improve what are not too precisely. So reports come at different periods. One report comes today, one report comes tomorrow. So they
Okay,
should be once the reports start coming, the flow chart should be used.
You make means if you have these facilities, if it's still persistent recurrent hypoglycemia, help of an
is not, sir. TSH 3T4 is not. Only thing had only low serum cortisol, 8 times serum cortisol levels,
and
sir.
all that. So
And
those kind of things, hypopituitarism and those sort of things. And also, like if you need a real kind of analysis, we sent to Dr. Anil Jalan in Mumbai. So like Dr. Rahul Yadav was commenting, better to send together. So the sample is typically, it goes by blue dot or something, like, the DHL.
Okay, sir.
He is one of the real experts in India. So if it's kind of getting like refractory and you're not getting any diagnosis, if they can afford, that is things you can do.
Anil Jalan, sir.
Dr. Anil Jalan. So you can get in contact with Prashant. He may have the number.
Yeah. You can just note down my number, mobile number, and you message me. I'll forward you the contacts of him.
Okay, sir. Just tell me, sir.
Yeah, 89 712 99 527.
527.
Yeah.
Okay, sir. I'll text you the details, sir.
Yeah. We'll forward. You can directly talk to him. Okay, I'll forward his number. Yeah.
Okay, sir. Thank you, sir.
Yeah. Sir, Dinakar, sir, would you like to say a few things, sir?
Nothing, no questions. I think so, Nilesh, somebody was asked that questions from Varanasi. No problem. Okay. Everything was nice, really nice, very practical, doctor. As usual, I requested him very badly to do the practical things what periphery doctors need. So Rahul, very nice, excellent. And as usual, our Nilesh boy, very nice, excellent. Thank you very much.
One thing, sir.
Yeah,
Yes.
Dr. Dheeraj.
Yes, sir. Very good evening.
Good evening. Please go ahead. Sir, one last question.
Sir, I was just waiting for my number. Ultimately, I have forwarded the question to Dr. Dinakar, and he has forwarded it to Dr. Nilesh. But it is okay, sir. I am here, sir, and good evening to all of you, sir. And big congratulations to all the three speakers for having a magnificent presentation. And my question to Dr. Nilesh is, sir, there is a 7-month-old male baby admitted to my hospital on 27th of May with complaints of generalized anasarca and jaundice and has refusal to feed. His weight is 6.20 kg, and on examination he has a firm hepatosplenomegaly with shifting dullness and has having severe anemia. He has complained of jaundice since birth, which is increased in depth with passage of time. He has taken treatment by local pediatrician but didn't get relieved. Liver function was deranged. PT was very much high. Both PT and APTT both. Admitted here, blood, urine, ultrasound, and X-ray all will done. Put on antibiotics, albumin given, PRBC 2-part given, Lornet injection would come, and all the supportive treatment has been given to him. Symptoms have subsided, edema subsided, liver and spleen regressed, but they are still enlarged and firm. Hepatite is improved, but definite diagnosis is missing. What will be the clue to this question, sir, and how I will proceed further with
Looking at
respect
this,
to inborn of error?
Dr. Dheeraj, it looks like some. Hello, Dr. Dheeraj. Dr. Nilesh.
Yes, sir.
It looks like a hemolytic anemia. I think you have to evaluate hematologically. You have to do all kinds of, the retic count, smear, and all of that.
Achha.
And of course, there is one possibility. Other thing is some sort of a liver. It's a wide group actually. So the liver is affected, and it looks like there may be a hepatic failure here, and possibly portal hypertension also. Like he had ascites and all that. So
But, But the portal system is normal ultrasound. Only the liver texture is changed along with the kidney texture also, sir.
Okay.
Echogenicity is increased there.
Okay. So there are different things. One of the things that comes to my mind is like something like Wilson's. Can you hear me? Wilson's.
Yeah. I have here.
Wilson's disease is one thing, hemolytic anemia, and this one, you know, all these things, anemia with hepatic failure and kidney involvement and all that. So maybe doing evaluation there. One thing is probably getting it evaluated through a gastroenterologist. Other causes of liver involvement. Did you do these tests, the hepatitis B and all those sorts of?
All the viral marker negatives. Hepatitis B, C, HIV, all the things have been done.
Okay. So essentially, hematological or disorders like Wilson's probably you'll have to consider.
Yes, sir.
No, maybe anyone else, Dr. Rahul?
No.
Whether we go for this tandem mass spectrophoria TMS, sir?
It is worthwhile doing it to see group of disorders. See things like alpha-1 antitrypsin deficiency.
Yeah.
So for that, I think you'll have to do genetic testing though.
Okay.
So those.
Is there any chances of tyrosinemia, sir, in this case?
Tyrosinemia typically type 1 and all has a very early onset. So,
yeah.
But of course, I think you should go for the full metabolic testing. It's such a heterogeneous group.
Yeah.
So it is, you know, but specifically, you know, this. So specifically, I think full metabolic testing and also looking at the things like Wilson. So you may need genetic analysis also.
Okay, sir. Okay.
Sir, hello.
Hello. Yeah. Please go ahead.
Suggestions?
Regarding hypoglycemia, sir, it can be due to the glucose malabsorption disorder, and simply we have to change the diet from glucose to fructose-based diet can improve the situation in this circumstance. Fructose-based diet, sir.
Yeah, Rahul sir.
Yes. This question is for me or Nilesh?
No, that is not the question. I just wanted to say that repeated hypoglycemia when no findings are coming, though the laboratory tests are positive, we can assume that it can be due to the glucose malabsorption, and the change from glucose to the fructose-based diet will have some improvement in this situation.
No, here we are trying to treat without diagnosis.
This probability is there that when we malabsorption of the glucose and simply the change of the diet from glucose to the fructose will definitely do some help to the child.
I fully agree with the sentiment here. This one that you must have seen some babies before who actually benefited from fructose-based diet. Actually, so there is a set of cases where actually it is called a glucose galactose malabsorption. In glucose galactose malabsorption, we get actually repeated diarrhea, hypernatremic dehydration, acidosis, and all those things. They do benefit from actually this sort of removing all the glucose from diet and replacing with fructose. But it is a very small subset. But so this one, it is to be used for specific diagnosis. Usually what happens in these cases is usually many times we try various therapies without diagnosis. So scientific approach should be first of all where to diagnose and then where to treat.
Okay, thank you, sir.
Prashant?
Yes, sir.
Any more questions, dear?
No, that's it.
Thank you for all both the speakers, 3 speakers. Thank you. Very nice discussion. Okay. Anything else you want to tell from NNFK Karnataka? And you have displayed. Actually, Genwork is giving. There is what is it, 5 keys and 17 keys for the hearing test. What Dr. Rahul was explaining, one is OAE, another is BERA. They're having, all the people are having. If anybody is interested, they can contact. Number one, hearing test. Even in the periphery, village, wherever you want, you can diagnose it. And it doesn't need any hearing test for specialist or something like ENT. Definitely in all the places, ENT doctor will be there. You can take his opinion. So number one, even they have the ROP screening machine that is called 3 Netra. Even they will give training once if you will take that machine. So it will be, everything is, even once you take the image, they will give what is the grade, whether it is plus disease, whether it is increasing posterior ROP, anything they will only tell you. It's all documented, legally approved. It's a very nice machine. In the periphery, definitely like us, when I am going to periphery, definitely I will be needing this. Number one. So, and even treatment wise, if you take that machine regarding the laser therapy, the company will assist you. So that is the things I want to tell you. Take the growth charts, Rahul will explain you. Number one, IEM, definitely Rahul I have told very, very clearly. If you suspect anything, please do the IEM studies. So how to send everything, it has been explained by 2 speakers. Thank you, Dr. NILESH RAO, Dr. Rahul and Ganesh. Thank you, NNFK and all the president and all our joint secretaries. Thank you, sir. Kishore, sir. Bye, sir.
Thank you very much, sir. Thank you, Dr. Rahul. Wonderful lecture. Thank you, Dr. NILESH, and thank you, Dr. Ganesh. Thank you all the participants. Thank you. Bye.
Thanks a lot.
Bye.